Hello and welcome. In this video, we are going to talk about intrahepatic cholestasis of pregnancy. We will discuss the definition, the risk factors, and the etiology of this condition, and we will also find out how we should investigate, how to diagnose, how to treat, and when to deliver the pregnant patient. Hepatic cholestasis of pregnancy is a hepatic disorder which is characterized by pruritis and an elevation in serum bile acid levels. Although intrahepatic cholestasis of pregnancy poses little risk for women during pregnancy, the condition carries a significant risk for the fetus, including complications such as preterm delivery, meconium-stained amniotic fluid, and stillbirth. Intrahepatic cholestasis of pregnancy occurs in approximately 1 to 2 per 1,000 pregnancies in the developed world. And it manifests in the third trimester with a mean onset at 30 weeks of gestation, and symptoms usually resolve after delivery. The differential diagnosis would include viral hepatitis, autoimmune hepatitis, primary biliary cholangitis, and cholelithiasis. Geographic variability exists, and limited local hospital-based studies suggest prevalence of 3%. In developing countries, the rates can vary from 1.5 to 4%. Apart from geographic variability, other risk factors include advanced maternal age, multiparity, personal or family history of the disease, pre-existing liver disease, and a history of cholestasis while taking oral contraceptives. Etiology of ICP is multifactorial, including genetic, hormonal, and exogenous factors. This condition is due to abnormal biliary transport resulting in saturation of the hepatic transport system. Recurrent familial intrahepatic cholestasis of pregnancy has been described as a heritable defect and can be linked to a gene which encodes for a canalicular phospholipid translocator involved in bile duct secretion of phospholipids. Mutations in this gene may account for up to 15% of cases. Female sex hormones play an important role, as almost all cases are seen in the third trimester, when estrogen levels are rising. Estrogens are also known to be cholestatic, and administration to non-pregnant women with a history of cholestasis during pregnancy has been shown to induce signs of cholestasis. Other hormonal influences include progesterone levels. So abnormal progesterone metabolism may also play a role in developing intrahepatic cholestasis of pregnancy, as elevated levels have been found in such patients. Exogenous progesterone also has a role. A study has shown that 64% of patients who developed cholestasis during pregnancy were taking oral micronized progesterone to reduce the risk of preterm labor. In patients who experienced a relief of pruritis before delivery, 70% experienced relief after withdrawal of progesterone, and another 10% did so after a decrease in their progesterone dose. Although this study is very old, but still it points to an important relationship of hormones with the chances of getting intrahepatic cholestasis during pregnancy. So what are the symptoms of intrahepatic cholestasis? Patients will usually experience generalized pruritus that begins in the periphery, often worse on the palms of the hand and the soles of the feet. Gradually, this pruritus will move centrally to the trunk and to the face. The pruritus will persist and worsen as the pregnancy continues and resolves within 48 to 72 hours of delivery. The pruritus is often worse at night and may be so severe that it causes sleep disturbances, irritability, and psychiatric disturbances. Approximately 10 to 25% of patients will develop jaundice. This usually does not happen immediately, but will take 1 to 4 weeks after the onset of pruritus. It's significant to note that no rash is present in association with the pruritus. However, some patients may be so disturbed by the pruritus that they will scratch themselves, and several excoriations will be seen on the hands and the arms as well as the legs. Much later on, patients sometimes develop constitutional symptoms such as chills and abdominal pain, and some patients may also develop diarrhea or steatorrhea. As far as the diagnosis is concerned, usually the diagnosis is based on clinical symptoms with some very common laboratory findings. Common lab values include elevated bilirubin levels and elevated transaminases, which will vary from a very minimal rise to 20 times the normal values. The most sensitive and important laboratory value for diagnosis is that of serum bile acids, and this may be the only lab abnormality or the first abnormality, and it's used as confirmation of the diagnosis. These patients will have levels of bile acids above 10 moles per liter, and they may be as high as 100-fold of the normal. The lab values will usually resolve within 2 to 8 weeks of delivery and will follow the resolution of symptoms, which will be much earlier. A liver biopsy is rarely needed for diagnosis, but if there is a doubt that there is a more serious liver disease, then the only way to exclude that would then be to do a liver biopsy. The obstetrician will not make the decision for the liver biopsy, and therefore this will be done by the multidisciplinary team if the patient has very severe symptoms. From an obstetrical perspective, as the condition is in the 3rd trimester, and if bile acids are too high, the clinical decisions for delivery of the baby will be taken irrespective of biopsy and its results. If the biopsy is performed, it reveals cholestasis with minimal or no inflammatory changes in the liver cells. Most guidelines will recommend the following treatment. Owing to an increased risk of fetal complications, early delivery is recommended from 37 weeks onwards. Ursodeoxycholic acid at 10 to 15 milligrams per kilogram should be administered to women for symptomatic improvement. And there is also some evidence now to show that it helps in the fetal outcome. Cholestasis has the potential for severe fetal consequences, which include fetal distress, prematurity, and stillbirth. Therefore, such patients should be treated at centers which have the capacity for treating preterm babies. The management will include symptomatic treatment of the woman, as well as close monitoring and planning an early delivery for the fetus. Medical treatment of choice is ursodeoxycholic acid with doses of up to 1 gram per day. A Cochrane review has found that this improves pruritis over the placebo, and some trials have demonstrated improvement in levels of liver enzymes, as well as shown enablement of delivery to occur closer to term. Cholestyramine may also be used to reduce pruritus in total divided doses of 10 to 12 grams per day, but this is less effective in comparison to urso and has more side effects. Fetal mortality in patients with cholestasis has been recorded to be as high as 11%, and the cause of the mortality is still not known absolutely. Fetal mortality does not seem to be due to chronic uteroplacental insufficiency, but rather to an acute anoxic injury. Some investigators believe that meconium, which complicates up to 45% of these pregnancies, causes umbilical vein constriction, thereby leading to fetal death and hypoxia. The cause for increased meconium passage remains unknown. Once weekly non-stress tests are a common method of fetal surveillance, and this often is begun at 34 weeks of gestation or as soon as the diagnosis of cholestasis has been made. But this is not necessarily a good predictor of fetal outcome. In one study, all but one fetal death in the treatment group occurred within 1 week of a reactive non-stress test. Consensus on the timing of delivery in women with cholestasis, and most guidelines recommend early delivery at 37 weeks gestation. Some older studies show that once fetal lung maturity has been confirmed, then the baby can be delivered even before that. The prognosis for intrahepatic cholestasis of pregnancy is good with the mother, and symptom resolution takes place very soon after delivery. There is a small risk of persistence after delivery in some rare familial forms of cholestasis. Those women who develop cholestasis of pregnancy may be more susceptible to developing more serious liver diseases, which include chronic hepatitis, non-alcoholic liver fibrosis or cirrhosis, hepatitis C, gallstones, cholecystitis, and non-alcoholic pancreatitis. Cholestasis will reoccur in 45 to 70% of subsequent pregnancies. So the cholestasis is associated with spontaneous preterm labor, meconium-stained fluid, and perinatal mortality. There is also an increased risk of iatrogenic preterm births. The cause of preterm labor is unknown, but in vitro studies have demonstrated that the myometrium in patients with cholestasis has a more intense response to oxytocin in comparison to that of women without cholestasis. As would be expected, elevated rates of respiratory distress syndrome exist in preterm infants. But RDS rates are also elevated in cholestatic patients who are delivered at term, suggesting that there is a mechanism which exists throughout which cholestasis itself contributes. However, with better management of neonates of respiratory distress syndrome, the outcomes have improved. The rate of stillbirth will increase after 37 weeks gestation, thus supporting active management of delivery at 37 weeks. But case reports of fetal death from 31 weeks onwards do exist. The Royal College guideline has shown a correlation of levels of bile acid with disease and prognosis. Cholestasis can be categorized as mild if the raised bile acid level is less than 40 μmoles per liter. It is moderate if it is between 40 and 99 μmoles per liter. If the bile acid levels are greater than 100 μmoles per liter, then it is considered to be very severe. Mild cholestasis is associated with a 0.13 risk of stillbirth, moderate with a risk of 0.28%, but severe cholestasis has a stillbirth risk of 2 to 5%, which is quite significant. There are a number of guidelines which have been published on the management of cholestasis during pregnancy, and these are regional, national, and international guidelines. The most commonly followed guidelines include those of the Royal College of Obstetrics and Gynecology, also known as the Green Top Guideline, published in 2022, and the International Society for Maternal Fetal Medicine Guidelines, which was published in 2021. There are some differences in the guidelines of the Maternal Fetal Medicine Society and the Royal College. So let us have a look to see what is the difference. For the diagnosis of cholestasis, the Maternal Fetal Medicine Guideline considers any elevation in bile acids above the upper limit of normal in the setting of maternal pruritis as a diagnostic marker of intrahepatic cholestasis of pregnancy. While the Royal College guidelines require a pregnancy-specific elevated bile acid level of greater than 19 millimoles per liter for diagnosis. Regarding the treatment of intrahepatic cholestasis of pregnancy, the maternal fetal medicine recommends URSO as the first-line treatment for pruritis. The Royal College guideline recommends against the routine use of URSO because of a lack of evidence regarding maternal and fetal benefit. The Maternal Fetal Medicine Society recommends fetal surveillance at a gestational age when abnormal fetal testing would result in delivery being performed, whereas the Royal College does not recommend any fetal testing beyond fetal tick count assessment. The maternal fetal medicine recommends delivery at 36 to 39 weeks of gestation for intrahepatic cholestasis of pregnancy with bile acid levels of less than 100 millimoles per liter and delivery at 36 weeks for bile acids levels of greater than 100 millimoles per liter. The Royal College recommends serial assessment of bile acids with delivery timing stratified between 35 and 40 weeks gestation according to bile acid levels. With this, we come to the end of the video. If you like the video, then please subscribe to the channel, press the like button, share with colleagues and friends, and send your comments about how you would like this channel to progress. Do press the bell icon for notification of future videos. Thank you and goodbye.